I did my service learning project on narcotics, specifically prescription opioids, and the dangers involved in using them and the potential for dependence or addiction. Most of my information came from the National Institute on Drug Abuse, and as I suspected, it just said mostly that patients are uninformed or misinformed about the dangers and risks involved in using prescription opioids, things like Percocet and Vicodin, sometimes morphine for chronic pain patients, even Schedule IV drugs like tramadol can be dangerous. And it was a problem because addiction to opioids can lead to other drugs, or it can lead to dependence on that opioid itself. The NIDA said that heroin actually binds to the same receptors in the brain as things like oxycodone. So that is a potential danger, not necessarily for the older population who's using it for post-surgical pain. You would see that more in adults, like in their 40s or younger. The methods that I used or would propose could be used to fight narcotic addiction. I personally, for my service learning project, created a pamphlet on narcotics. Basically, it was very short, just had a little bit of information on it. Most of my project was discussion based, so this was just a supplement to the conversations that I had with patients. Just got some information on what narcotics are, some signs of addiction, so knowing if you are becoming dependent or if a loved one is becoming dependent on opioids. And then I did suggest with every patient that they would talk to their doctor about the risks of being prescribed opioids and taking them to manage pain, maybe seeing if they were predisposed to addiction, then they could find another route of pain management. Another way that they could battle prescription opioid addiction would be that the prescriber, the doctor, would give the patient a little more information on the risks involved. It's pretty typical that prescribers simply just give them a prescription for a pain medication if they present a problem with either chronic pain or post-surgical pain, and then they just take it to the pharmacy and that's that. Now with genetic testing, they can know if a patient is going to be predisposed to addiction. Also with family history, they should be more thorough about what they go through there, just making sure that the patient is the right candidate for prescription opioids to manage their pain. The third method would just be getting that same information from the pharmacy where they pick up the prescription. This just covers all of the bases, makes sure that they are fully aware of the risks, the dangers of opioid dependence and addiction. Typically, when a pharmacist counsels a patient on a scheduled drug when they're picking it up, it's on the side effects of the drug and not necessarily the dangers of addiction or dependence. So if those things were presented at the time of pickup, maybe the patient would be more conscious of taking the drug as it's prescribed, really following the directions, being more concerned about whether or not they should take that drug, if their pain is severe enough to take that drug, or possibly opting to get a different prescription for something less controlled, something like tramadol. Though tramadol is a narcotic, it is a Schedule IV, and it's not as addictive as something like Percocet. So I did my service learning project at primarily the physical therapy office where I work, and at the pharmacy where I work. I work much fewer days there, so most of my project was done at the physical therapy office. It was mostly discussion-based. I spend at least an hour with every patient that I'm with. Most of my patients are older population, post-surgical, a lot of knee replacements, shoulder replacements, things like that. Patients who are on painkillers. So it was good to just ask them how they were feeling when their last dose was, and just let them know the risks of the medications that they're taking. I did make sure that they knew I was not a physician, I was not a doctor, I was not in a place where I could counsel them. I was just giving them some information that I had personally found useful, and I let them know that they should talk to their doctor about the possibility of changing to a different method of pain management if they felt that their pain was well controlled. I helped the patients get some information. Most of them were actually just either uninformed or misinformed. I did have one patient who, just for example, was taking Percocet and intermittently, so normally the doses are like 1 every 6 to 8 hours. Intermittently, they will take something like ibuprofen. Well, she was choosing to take Tylenol. It wasn't necessarily a narcotic overdose risk, but the Tylenol that she was taking had acetaminophen in it. The Percocet that she was taking had acetaminophen in it. So she was predisposed to a risk of overdosing on acetaminophen. So I just let her know, go ahead and talk to your doctor. I'm sure they told you to take ibuprofen instead of Tylenol. It would probably be best that you opted for that in between. And she did agree. She said that her physician had told her that. So overall, this project just opened my eyes to the dangers of taking prescription narcotics, even though they are legal and they are used for medicinal purposes. It is very important that people are cautious about what they take, how often they take it, and it's important that they talk to their doctor about the risks, that they're fully informed and very comfortable taking the medications that they're prescribed. I really like just engaging with my patients in that way. It gave us something to talk about. I was able to inform them and let them know that this was something that I was learning about, and it was really interesting to me. My target audience was really receptive. I don't think anybody felt like I was specifically targeting them. I don't think anybody was offended by the information that I gave. It was just a very light discussion-based kind of project, and I think that aspect of it was very beneficial. I would have liked if my workplaces would have allowed me to set my pamphlets on the counter, but they were not approved by corporate, so I was not allowed to do that. But I did get to use the information in it, and I did get to show a patient or two what I had put together. It would have been nice if I could have set up a table or had a more diverse audience. Most of my patients are older. I didn't really get to talk to any younger people who would be more predisposed to taking something like heroin. So those who would be exposed to the danger of using prescription drugs as a gateway. It would have been nice to just have a more diverse audience, getting some younger people involved there. And then just some barriers at the pharmacy specifically. I'm not allowed to legally counsel patients on any drugs whatsoever, specifically like letting them know the dangers and risks involved with them. That's the pharmacist's job. So that was kind of a barrier for this project. So that's also a reason why I did most of what I did at the physical therapy office. In the future, it would be nice if those barriers were not in place and I were in an environment where I could just freely inform people about the dangers of narcotics, have a little more time on my hands where I'm not on the clock. Something like that would have been nice. But overall, it was a good project. I really enjoyed engaging with the community and letting them know just more about the things that they were taking. Thank you.